The following presentation occurred during the 2022 South-Southwest Mental Health Technology Transfer Center, MHTTC, First Episode Psychosis, FEP, Conference. This conference occurred from June 1st to June 3rd, 2022 in a hybrid format, with approximately 150 in-person participants in Austin, Texas, and 300 virtual participants from around the world. Conference attendees shared a range of identities and positionalities, including those with lived experience, family members, providers, and researchers. The 2022 theme of innovation and sustainability highlighted not only the radical advancement within early psychosis programs over the past decade, but also the continued transformation that we hope to see of mental health structures and research serving youth and young adults living with psychosis. This conference was an opportunity to engage in shared dialogue across difference, struggle with new ideas, and re-envision a future for mental health structures for youth and young adults living with psychosis. This conference was coordinated and hosted by the South-Southwest Mental Health Technology Transfer Center, MHTTC, in Region 6. An initiative funded by the Substance Abuse and Mental Health Services Administration to provide free training and ongoing consultation to all professionals that serve individuals with mental health needs. Region 6 includes the states of Texas, Oklahoma, New Mexico, Arkansas, Louisiana, and our tribal communities. The South-Southwest MHTTC is a project of the Texas Institute for Excellence in Mental Health, which is housed at the Steve Hicks School of Social Work at the University of Texas at Austin. By way of a disclaimer, this conference was prepared for the MHTTC network under a cooperative agreement from the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. The opinions expressed throughout the conference are the views of our speakers and do not reflect the official position of the Department of Health and Human Services or SAMHSA.
I have the privilege of introducing Dr. Oladunni Oluwoye. Dr. Oluwoye is an assistant professor in the Elson S. Floyd College of Medicine at Washington State University and the co-director of the Washington Center of Excellence in Early Psychosis. She received her BS in psychology from the University of Alabama at Birmingham, an MS in clinical psychology from Alabama A&M University, and her PhD in health promotion and education from the University of Cincinnati. Dr. Oluwoye is the lead evaluator for New Journey's network of coordinated specialty care programs in Washington State and is supported by multiple grants from the NIMH, including a Mentored Research Scientist Career Development Award, or KO1. Her overarching research focuses on the early onset of serious mental illness, specifically psychosis, among racially and ethnically diverse families. She also focuses on the development of strategies to increase engagement and service utilization. Through this work, her hope is to improve pathways to care and advance the availability, acceptability, and effectiveness of mental health care among racially and ethnically diverse populations. Today, she'll be presenting the talk, Family Member Support Person Engagement During Care for First Episode Psychosis, Challenges and Strategies to Move Forward. This talk will provide an overview on the impact of family members or support persons on the pathways to mental health services and while receiving care for loved ones in the early stages of psychosis. She will present recent work as well as several strategies used to improve family engagement in early intervention services, as well as culturally informed approaches used to address racial inequities. And with that, please welcome Dr. Oluwoye.
Thank you for having me today. This is my first conference since 2019. I know. And I was telling Sam and Jennifer earlier, this is also the first time I'm being away from my 5-month-old. So there were cries and tears from me, but not from anybody else in my family. And then I got told to get out of the house by my partner. and catch my flight. So I am super glad to be here. A lot of my work is focused on family engagement, and I specifically focus on racially and ethnically diverse families with a big attention on Black African American families. And so that's where a lot of the research it is that I do. And so the presentation will be talking about pathways to care, and why pathways to care and understanding those experiences are extremely important, because those experiences shape how people perceive treatment when they show up at CSC services. And then I'm going to be really focusing more on what barriers and what family members have told us are some major barriers to engaging in treatment, and then some of the things that we're doing in Washington State and elsewhere as it pertains to improving family engagement prior to and during CSC programs. So while that is being done, Sam kind of went over my background. I'm a health services researcher, and my PhD is in health promotion and education. And so that allows me to have this perspective of thinking about not just the intervention itself, but really thinking about the community and society, and how all of those things that happen within those different realms really impact how individuals and families engage in services. So, oh, we can start right there. Yeah, we can start right there. I have no financial disclosures. Oh, it's working. So these are my learning objectives. Sam kind of gave a debrief about what I will be talking about, and so did I. I'm clicking twice. And so the best place for us to start is pathways to care. When we speak about pathways to care, it's usually when we're talking about everything that happens prior to families showing up at coordinated specialty care programs. And so a lot of the times in research and even throughout clinical care, we pay a lot of attention to the duration of untreated psychosis and those experiences that happen during that time. And what some of my colleagues and I are really saying is that it doesn't just start at the duration of untreated psychosis or the onset of psychosis. These experiences predate that. The experiences kind of end up in the prodromal period, and even the experiences prior to then. And so there's been literature out there that has really looked at neighborhood level factors and how that pertains to the onset of psychosis, how discrimination can lead to psychosis-like experiences. And so all of those things need to be considered, especially when we're thinking about ways to engage family members and having a better understanding about the experiences that they have gone through in order to get to those services. So when we think about pathways to care, so many things happen during that time. There's the misattribution of symptoms, where some family members have said, well, it's substance use. And lo and behold, it is substance use. And then there's also the onset of psychosis. There's stigma involved in it, whether it's societal stigma or whether it's stigma ingrained within a family and how they view mental health. There's also a level of uncertainty. There's multiple diagnoses. I wish we lived in a world where it was onset of psychosis and then families end up in coordinated specialty care. And that for some people may happen, but for the majority of families, that doesn't happen. It is the onset of psychosis, multiple diagnoses, multiple interactions with mental health care people, multiple interactions with other sources and resources within a community. And so this causes a level of confusion, a level of distress already in a time where families are trying to figure out what to do and they're much in need of services. And so all of this culminates into these positive and negative experiences. And so while families experience all of these things, positive or negative, racially and ethnically diverse families experience more difficult pathways to care, in that they're experiencing or have experiences with discrimination. And this is on top of the already hard way and the hard path of getting to services. And so I'm going to put up a quote from a family member that I had the opportunity to speak with, and she's an African-American mother. And in this quote, it really kind of exemplifies multiple different things. First, it kind of shows the experiences that she had with discrimination, and this is prior to care. It also shows the level of advocacy that family members have to do in order to get their loved one to the appropriate services. But it can also display how these experiences can cause a level of distrust coming into coordinated specialty care programs. And I think all of these things happen prior to individuals getting to CSC programs. And it's important to kind of understand this because these experiences tend to have an impact on how family members choose to engage once they're in CSC programs. And a little bit later on, I'm going to go in and I'm going to talk about the rates of family engagement in coordinated specialty care. So as we know, family members have a key role in facilitating the pathways to mental health services and other resources and support. And the reason why I put other resources and support is because not all families are seeking mental health services. Some families are just seeking services and support from other means outside of the mental health care system. And not all families, the end stop is coordinated specialty care. One, because not coordinated specialty care is not available in all places. And so there's an accessibility issue. And so what does that look like for other families? And so maybe they just end up being at a community-based mental health treatment that doesn't have an early intervention program attached to it. And so I think it's important to kind of think about, especially because we work in early intervention and coordinated specialty care, but that is not the end stop for a lot of families. The other thing that I want us to think about is, and I hear this a lot from clinicians within our program in Washington State, is that some people don't have family members. And so to really think about family members and support person, whoever that individual has identified as a support person. And so while I keep saying family members, I also want you all to think about that. I'm also talking about support persons and who an individual has identified as their support system. All right, so why are family members important? A large majority of family members, up to 88% of individuals, live and reside with a family member. Family members, as you know, are also responsible for keeping and attending appointments. They provide financial support, and they also provide emotional support. This is leading up to coordinated specialty care or the entry into CSC programs, but this is also throughout care and even after individuals have graduated from programs. Why do we involve families, you ask? I have an answer for that one. Family members are primarily responsible, so research out there, and a lot of this is just based off the research, and so I'm kind of giving you a summary so you don't have to read a whole bunch of articles online, is that they're primarily responsible for the initiation of treatment and primarily also responsible for first hospitalization. And so for a lot of families, it usually is a hospitalization and then they kind of end up into early intervention services. And so they are one of the main reasons why that care has been initiated from the beginning. The second part of that is research has shown us is that limited family engagement is linked to a longer duration of untreated psychosis. The third part is that interactions with family members during inpatient leads to the better connection to outpatient services, and that individuals are connected to services within 5 to 30 days after discharge from inpatient care, compared to individuals that did not have a family member involved, where you see this longer period of time between when a family member, between when somebody has been discharged from inpatient to when they connect to outpatient services. Oh, I got some animation on this slide. So when we take a look at some of the larger literature that is focused on older individuals diagnosed with schizophrenia, family contact is associated with better work performance. So really thinking about those functional outcomes. Living without a family member, the group in New York On Track New York really found that living without a family member at discharge and lack of family member involvement is connected to disengagement, on the early disengagement from services. And then family member, why didn't y'all tell me? I've already moved to the next bullet point. We're on the third one. Okay, so family engagement increases service user engagement, where we have seen that if a family member is engaged in services, the service user is more likely to stay in treatment for up to 7 months. And this is on the initial engagement. So if we are linking family members in that first appointment, we see a sustained impact on engagement for service users for up to 7 months in treatment. And so that kind of goes to show the level of impact just family members attending services it has on service users and their outcomes, and even process outcomes, which is engagement. So within this paper that we published in 2020, we really focused on what family involvement prior to services looks like and how that impacts African-American families when we compared that to white families. And what we saw is that less than 50% of African-American family members had contact with mental health professionals prior to entering into coordinated specialty care. We also found that unlike white individuals, Black African-American families, family contact was extremely important prior to services, and that it had an impact on their quality of life outcomes once they were in CSC programs, when we compared that to people that did not have, that did have family contact at prior to CSC. And so what this really is telling us is that the level of importance that while family engagement is extremely important, even in the pathways to care and while in services, for Black African-American families, it has a direct link to quality of life outcomes. And so a lot of you all are working in CSC programs. And so the question is, well, pathways to care, that's stuff that we that's stuff before they get to us. And it's something to think about, especially as you're engaging with families once they get to your services. Did they have contact with mental health professionals prior to engaging in family support and in education in CSC programs? What were those experiences like prior to care? Because all of those things inform how they, one, view CSC and the mental health services it is that you're providing. But it's also, it allows you to get a better insight in order for you to tailor care. And later on, I'm going to kind of go over one instrument that we use in Washington State that really helps us to better understand those experiences prior to and how we can kind of weave that into family education and support during CSC. Okay, so then we've reached coordinated specialty care. And so you've been hearing me talk about family engagement, and I'm pretty sure you hear family engagement thrown out a lot of the times. And a lot of that generally lands on attendance. Our family members attending services, but engagement can be captured in many different ways. We think about engagements, there's other ways for you to think about it. So is a family member staying in contact with you by phone and not necessarily being able to attend appointments because of barriers that may be in place? Are they still contacting you by email? And so you're thinking about these multiple different ways that individuals can contact you, and not just holding on to whether or not family members are actively attending family psychoeducation appointments. Because for some families, there may be extenuating barriers that prevent them from coming in, such as work, conflicting schedules, which we'll kind of go into later. But that doesn't mean they're not necessarily engaged in treatment. And so I say all this to say, we're still focusing on attendance. So a lot of the literature that the slides that I'm gonna show after is really focused on continuous engagement, which is that sustained engagement throughout coordinated specialty care. But it's focused on our family members actually attending services. And so also think about, this is also prior to COVID, before everything transitioned into telehealth and virtual services, where some of that engagement may look a little bit different after the fact. I changed my slides. Okay, so family engagement throughout CSC programs, if we think about it nationally, varies, where we have various engagement rates throughout care. So are you all familiar with the RAISE trials? Yes, I see some nods. RAISE, EpiNet. Yep, okay, so you have RAISE, and RAISE led to EpiNet. So RAISE is what came about from RAISE's Navigate. And so within that study, it was a 2-year study. It was a randomized controlled trial. I'm taking you back to statistics and research design methods classes, is that we found extremely low rates of family engagement, where on the left-hand side is community care, which is basically non-early intervention services. It's standard outpatient services where we see these extremely low rates across race and ethnicity. And then on the right-hand side is we still see low rates. It's better than what we see in standard care, but we still see less than 40% of families are engaged in services. And the orange, I don't know if you can see the very top bar, but blue is non-Hispanic white, orange is non-Hispanic Black, gray is Hispanic, and yellow is other race ethnicity. And so what we found in this study is that Black African-American families are significantly less likely to participate in family education and support in coordinated specialty care programs. And I think some of the takeaways that we get from this is that, well, with coordinated specialty care, we do better. It's way better than what standard care does, but it's still pretty low when we think about the level of engagement we want from family members in services. So that was a research study. And so now let's look at rates from actual implementation outside of what a research study is showing us. So in Arizona, their engagement was 22% participated in individual family psychoeducation, and 44% of families participated in group psychoeducation. And so those rates are still along par with what we found in the research study. In On Track New York, they kind of looked at engagement a little bit differently, where 84% of family members had contact with coordinated specialty care providers at 3 months. But I think what's important for this is that 41% of service users requested conditional or no family involvement. And so the question from that is, well, what do you do when the service user or the individual receiving services says, no, I do not want my family member engaged in services? And I think what came about from this study, and I think what's super interesting, this is a study published by Nev Jones, is that how can we think about what type of services we can provide when a service user says, no, I do not want my family member engaged? And so within On Track New York, there's 3 different markers for what they look at. They look at, yes, I want my family member involved all the way. Absolutely need my family member. There's a conditional where the service user can set different types of criteria for how they want their family member engaged. And then there's the absolutely, no, I do not want my family member involved. And so in Washington State, we think about family engagement in a similar way. Can we provide family psychoeducation to individuals, to family members, even if the individual says no? So are we opening up that possibility for family members to engage in group psychoeducation? And the answer for that is, well, yeah, we can do that. They can participate in these group sessions where they're still able to get the benefits from family psychoeducation, but there is a clear line between this is not a part of the services it is that we're providing. There's no transmission of information about the individual and how they're doing in treatment. It is, we're giving you education about psychosis, we're giving you resources and an ability to connect with other people. So that's one way to think about that. And so I throw it back at you all to think about, are there additional things that you can do to provide resources to family members who are in much need of those resources, especially when a family or the loved one says, no, I do not want them participating in my treatment. Are there other resources that are available at your agency for that family member to engage in? Are there other resources within the community that are available for that family member to engage in? So at least they're up to breast on what psychosis is, creating a community for themselves, and still getting those benefits from psychoeducation without going beyond or moving beyond what your service user has asked for. So in Washington State, where I live, where it is cooler than it is here today, much cooler. I grew up in Alabama for half of my life, and I was not prepared for it to be so humid. Maybe it's because I live in Washington and we're just creeping into the 70s, like we're coming out of the 60s. And then I was just like, it's 90 degrees and it's super humid here. I had to literally unpack sweaters because I was bringing sweaters. I was like, what is going on here? I need to come back to the South more often. So in Washington State, where it's green and luscious, we looked at family engagement, and 70% of family members participated in at least one individual family psychoeducation. And then 39% participated in the first month. And the reason why I split this part out is because this allows us to take a look at initial engagement, that first family psychoeducation appointment, and continuous engagement. So what this is kind of telling us is when we hook people in and when family members are engaged, they stay engaged. It's what about the people that we don't hook in on the first try? How do we get them engaged in services during that first month? Because that first month is extremely important because it's linked to continuous engagement, and it's actually a predictor for continuous engagement. So I have a nice graph for you here. And so in this graph, we looked at 24 months across care. And so this darker line, which is the top line, really shows how many family psychoeducation appointments were scheduled. And of those, the gray line is how many of those were attended. And so what this really is showing us is, one, family engagement is still pretty low, right? At intake, family engagement is low. But two, once we have, bless you, once we have family members scheduled for services, they continuously participate in services. So there is something about CSC models that really hone in on the fact that once individuals are getting those services and you're going through those modules and you're doing the work with families, they remain engaged. But it's about the 50% of individuals that we're not engaging and that we're not hooking in. And so that's where we kind of parcel it out into two different things: initial engagement and continuous engagement. Initial engagement is where we have to really think about what happens in pathways to care, because that is what is predicted and linked to why individuals are not engaged in the initial appointment. Continuous engagement is where we look at how do we get people continuously involved throughout services. And I think a lot of the work has focused on the continuous engagement, and there hasn't been a lot of work focused on that initial engagement in services. Okay, I just said that part, so we can skip through this one. Okay, so summary of what it is that I said. Early contact is linked to better outcomes. Negative experiences lead to lack of engagement, and that's negative experiences in CSC programs, and that's also negative experiences that happen prior to when these families come to your front door. And then the third one is engagement increases engagement. Family engagement increases service user engagement, and initial family engagement is more likely to be a predictor for continuous family engagement. So 3 simple things. I said all of that in like 20 minutes, and I could have just presented you with one slide. Okay, so I'm a researcher, and we did a research study where we had about 170 family members participate in an online survey to tell us what their barriers to care are. And so within that, we had them fill out a survey to really look at stresses and obstacles that compete with treatment, treatment demands and issues, perceived relevance of treatment, relationship with the therapist, and critical events. And so I'm going to go over, here's what they said. So about 75% of families said one of the biggest obstacles and stresses to treatment was that they experienced stress in their own life, which is why they were not engaged in services. And I think that that is the number one thing when I have the opportunity to have family members share with me their stories, is that that is one of the biggest things. That I've got my own things going on. I have my own work. I have other children, and I have other stress that's going on in my life. And that is the biggest barrier to engaging in services. Right after that was my child refused to come to a session, which is why they did not show up to services. And then the third most reported barrier was that appointments conflicted with other activities. And I think that time and time again, we kind of hear that from family members, is that they would love to attend, but there's a conflict in schedule. And so they're not able to attend. The next one was treatment demands and issues. So scheduling of appointment times made it hard for them to attend. And I think that you probably have all encountered this, is that I am not able to come to a scheduled session simply because I have work and it's hard for me to attend. And so that could just be a barrier between their own schedule and the schedule that is provided from this 9 to 5 schedule that is available. Other things that this could be because is simply because there's other things going on in life. And so this one really goes hand in hand with the previous slide. 47% of families had trouble understanding their loved one's treatment. 42% of families said that they did not have enough say about what goes on in their loved one's treatment. And 29% of individuals said that information in session handouts seemed confusing and hard for them to understand. So in addition to barriers with scheduling and not being able to attend, some of the other biggest concerns was, one, they felt like they didn't have enough say in their treatment, which I'm sure you have heard time and time again. Two, the other part is that they didn't understand the treatment. And so a couple of slides from this, we're going to actually reverse a lot of these barriers and thinking about how we can kind of address them. So the third one is perceived relevance of treatment. One of the biggest things that family members had said is that their loved one had a new and different set of problems. And so this goes into, I think about all of the stories that and experiences that family members have shared with me, and it really goes into one thing pops up and then something else pops up. And how do you compete with issues within a family unit that keep changing, especially when they're coming to you for first episode of Psychosis, but then other things kind of topple on of that. And I think that also boils into why family members feel as though the relevance of that treatment doesn't pertain to the issues it is that's going on. And that's simply because things are forever changing within their loved one's life and within that family unit. So relationship with the therapist. So the therapist did not seem confident that the treatment would work for my loved one. And I think that this one kind of goes to show, because it's a mixture of family members that had experience with coordinated specialty care and also family members that had an experience with standard treatment. And I think that, and this is just all of my thoughts because this is not exactly what family members had said, is that there is a little bit of confusion in one, when family members have multiple diagnoses, where family members have blatantly said to me, I've gone in and I've seen a physician and I've seen a therapist and they've diagnosed my loved one with major depression. And then 2 months later, they've diagnosed my loved one with bipolar. And then a couple of months later, they don't know what it is. And they think that it's a family issue. I'm abusing my child. And then a few months after that, they've diagnosed with my loved one with schizophrenia. And I think that all of that confusion boils into family members not being hopeful. Family members being, if not more confused from where they started from. And I think that this one, which is heavily endorsed by family members, really speaks to the fact that their engagement with different therapists and different clinicians really honed in on the fact that they felt as though everything was hopeless, and that there wasn't a treatment available that would help their loved one. Okay, so the last one is critical events. Interruptions in treatment was heavily endorsed. So essentially, the reasons why there were barriers or disengagement from treatment is because an individual got transferred to inpatient, or there was interruption of services. The second one was family dynamics or other family issues. So other things going on in the family unit, such as substance use, which interrupted treatment. And so therefore the family member had to kind of engage with other fires to put out within the family home. And then the third one was household changes, where there were changes to medical insurance. And so that's really thinking about if a family member is the financial and emotional support for a loved one, and they're working and they have their own things going on, and there's multiple conflicting schedules and they lose their job. Well, that has a big interruption in the type of medical insurance that is provided. And so that can be the biggest barrier to their engagement in treatment. So here is a nice summary from all of those different categories. And then we try to flip it around, right? So treatment relevance, family members' needs and expectations, being clear with family members what the expectations are, or understanding what their expectations are with treatment, and understanding what their needs are, because a lot of the time, family members' needs are also very different from service users' needs. And so finding a good level ground to build a foundation within family psychoeducation is extremely important. Stress management and flexibility. Flexibility is a little bit hard because nobody wants a call at 11 p.m. at night. Nobody wants that call at 11 p.m. at night. And so some of that are logistical concerns. Some of that is agency and program level factors that need to kind of be addressed, and how it is that we provide services to individuals. Really thinking about what areas within the family psychoeducation component really addresses stress management for individuals. And not just stress with them engaging with their loved one, but stress in how they're managing their home, how they're dealing with other different things that are happening within that household, and not just as it pertains to psychosis. Relationship building and consistency. Family members often generally say that they want clinicians that are consistent with them, that they don't have to chase around. And so that one speaks to really just building a relationship. And so I really like to stress on different ways that you can do that. It doesn't always have to be about in-person and attendance. Sometimes it could be sending an emails. We also use text messages. Sometimes it could be sending a text message. And so really build in that level of rapport with families. Treatment demands, clarity, and involvement. I think thinking about pathways to care all the way through CSC, family members that actually want to be involved truly want to be involved in treatment. And so finding a space where they can be involved and feeling as though they have an input in services is really important. And so after all of that quantitative work, we did some qualitative work that really honed in on these different components of care, where they highlighted multiple different themes. So they stress the importance of support, supportive interactions, not just in CSC, but also thinking about prior to care as well. Positivity, working with colleges, universities, and employers. So really building a connection from CSC programs to community organizations to improve that transition through care. I think for a lot of individuals, having that connection, one, can reduce that duration of untreated psychosis, making more organizations within the community more aware of services as well. I don't know how many times I often hear from organizations, I don't even know, our program is called New Journeys, and it's very similar to New Jersey. And it's not something we thought about prior to until we just see the NJ initials and everyone's like, New Jersey? And I'm like, no, it's New Journeys. And so a lot of the time we ask people, have you heard of New Journeys? And a lot of organizations within a community, I have no clue what New Jersey is or New Journeys is. And I think that building that relationship helps individuals connect with family members, families in general, more. And that really goes to community outreach. And I have a whole other spill about community outreach and mental health block grant stuff and what gets reimbursed and things like that. But okay, so knowledge. Having clinicians be extremely knowledgeable about what's going on within the community. When I had the experience of really talking with Black African American families, the biggest thing was I want my clinician connected to the community. I want them to understand the community climate. I want them to understand organizations and communities and resources in the community that they can then suggest to me, for me. And so that is really speaking to making sure that clinicians are able to understand the experiences for racially and ethnically diverse groups, and those experiences are not all of the same. And so really being thoughtful about how you engage with family members and what resources it is that you provide to family members. So understanding signs and symptoms is one of those big ones. Having available resources and services within the community is another big one as well. Are there local support groups beyond NAMI that are available for family members to connect with so they're able to receive additional resources within the community? Communication. Family members were really stressing the fact that they just wanted to be valued and listened to by clinicians. I was at a talk in Boston virtually, and where I think one of the clinicians was just like, well, no, I am not able to tell you what's going on with your loved one. And so somebody had asked her, well, then what do you do about family members? And she was like, well, you can just stay on the phone and you can listen to their concerns. And that's as far as it is you can go, and you can thank them for sharing their concerns with you without having to cross those boundaries between sharing information that you shouldn't be sharing with family members due to HIPAA laws. Bilingual staff was a major one. I think a lot of family members really honed in on the fact that I want staff that are able to speak my native language. I want staff that are able to not just speak to me, but also be able to address things with other family members as well. And then access, availability of services and timely referrals. I think if there are available services and if the referrals are timely, that you will reduce the amount of negative experiences that family members are engaging with. And a lot of these things are beyond CSC programs. These are more community level concerns that need to be addressed. And I recognize that, but I also think that these are things in order to improve mental health services, not just for FEP, but these are the things that we kind of need to think about, and how all of these different organizations and communities and mental health care and different systems of care kind of interact. So what other resources do I use? Has anybody heard of the cultural formulation interview? Yeah, Yeah. Okay, great. Yay. So I really like the cultural formulation interview. And in a study that we're doing, we actually modified the cultural formulation interview to use with family members, where some of the questions within that are asking individuals, what resources and experiences have you had prior to coming to our services? What has worked for you? What has not worked for you? How do you define culture and how culture is important to you? And really using that to build a foundation for the family component, to not provide or suggest services because the family's member has already said, I don't like that, and I don't want to go there, and I don't want to use those resources. Thinking about culture in not just thinking about race and ethnicity, but thinking about a culture that is meaningful for the family dynamic. And so once you think about that, those are the things that you can kind of ingrain through your services. And so I am a big proponent of the CFI. It's available online and it's free. And so it's something that you should absolutely kind of take a look at, and you can kind of piecemeal different modules together for the CFI. Okay, so current efforts. A lot of it is focused on family peers. So in New York, Kimberly Hoagwood, Dr. Kimberly Hoagwood is using family peers and that family peer network that they have established within New York to really improve family engagement in coordinated specialty care. So that's one effort that's being done. Dr. Maria Monroe DeVita in had to think about it, in Washington State. She is also using family navigators. And they also have a fantastic training that's available. It's called Psychosis Reach, where they're training family members to identify signs and symptoms, where they're training family members to be that bridge between services and provide additional support while in coordinated specialty care. So that's one element of that. We are using something we call FAMES. I don't know why we landed on FAMES, but we did. And it is something that is clinician-led. It uses the CFI. It uses multiple different forms of contact and really leaning on what those preferences for the family member is. Is it by text message you want to stay engaged? Is it by email? Is it by telephone? Whichever one is more conducive to your schedule to kind of address some of those barriers that we mentioned earlier. So that's one way we're using that in terms of engagement and making it more culturally relevant. And the third one is one that I am super pumped about. It just got funded. It is training Black African-American family peers to be in the community, to do a lot of community level outreach, to educate different organizations, to screen for clinical high risk in the community, and to catch individuals early and then improving that access to CSC programs. And if an individual is not eligible for CSC programs, connecting them to the most appropriate services. This one is one that is really enriched and embedded within the community. It is really looking at training family peers with lived experience to engage within a community that they are most familiar with. So a lot of engagement with Black churches, a lot of engagement with Black fraternities and sororities to educate them about psychosis. There's a lot of engagement with organizations such as the NAACP and the Urban League. And so that one I'm super excited about, and hopefully I can come back and tell you that it all went fantastic. And to see where it went. Okay, so I'm running out of time, so I'm gonna go super quick. Transformation that I would want to see is services that address the needs of family members, not services that address just educating family members about psychosis. And I think a lot of the time we tend to identify a lot of other issues that are going on within a family unit, whether it's a mother that is experiencing depression. And so where does she go for services? And I think that's the part that doesn't get as much attention in family psychoeducation is the case management portion of it, being able to connect family members to the appropriate services that they need for their own well-being and for their own support. The second part is improved navigation beyond between systems. I think that a lot of systems do not talk to each other, and that is what creates a lot of difficulties throughout care. From the criminal justice system to the mental health system, from foster care to the mental health system. I think that these are the places where we tend to lose a lot of people as people are transitioning between care. And if there was an improved navigation between that, I think that people would come into CSC programs with better positive experiences where they're ready to engage in services and they don't have all of these negative experiences that have already detached them from the services it is that you're providing. The third one is community-informed resources and support. This, I think, is more about thinking about outreach and targeted outreach. Outreach where we're thinking about how do we connect better with the Black African American community? How do we educate the community so they're able to see a lot of these signs and symptoms early, so they're able to engage with family members and get them to the appropriate services? When we spoke to Black families, we looked at their first context of care. It's friends. It's families. That is where people go to first. And if we're educating the community about early signs and symptoms, then we're able to connect individuals earlier to services. And then more diversity in the workforce. I think this is beyond CSC. This is more of a larger picture and a larger issue that stems all the way into educational system and entries and things like that. But I think that having a more diverse workforce is extremely important. I think individuals want to be able to see people to have that representation. And I think that that's important when engaging with families and service users throughout care. So drum roll, please. The ends.
All right. Thank you so much, Dooney. That was beautiful. So we have just a couple of minutes for our Q&A. So I'm actually going to start with our virtual audience. So Mordecai, is there any questions from the virtual audience today for Dooney?
No questions as yet. We're going to keep encouraging the virtual environment to pop those questions in there if you have them for Dr. Dooney.
All right. Thank you so much, Mordecai. It looks like we have a question from the in-person audience, so we'll start there.
Okay. What is your opinion of community Medicaid waiver programs / services for individuals and family members?
Pardon? Can you repeat that?
What is your opinion of community Medicaid waiver programs / services to individuals and family members?
I'm not familiar. Who asked that question? I don't know if he's able to. I'm not familiar with that.
Okay, I can speak loud.
Yeah.
I'm a native student in Texas. Like, for example, in Texas, we have like a Medicaid waiver program, for example, for individuals that may need additional services and transition services. So what happens when you put addition, you can have a waiver program. And so I go, I don't need my phone to speak loud.
The virtual people can't hear you. I'm sorry. It's the virtual folks.
Yes, so the question pretty much was like for the community, Medicaid waiver program, for example, in Texas, what we do, we have a program where individuals, when they're in services, they can have their name to be put on the list for community waiver programs to make sure that the individual have those wraparound services. And so when you mentioned about family engagement, I was just asking you about what type of community Medicaid waiver programs that you have like out in Washington, where you're from.
Well, I think I answered your question because I didn't know what you were referring to.
Okay.
I don't know what's available. I don't know what's available, but the moment that you ask that question, I immediately think about, well, what about the people that are not on Medicaid? So in Washington, it's 50-50. I don't know how it is here, but 50% of families in CSC have private insurance and 50% have public insurance. And so I immediately think about, well, what about the private care people, right? While I don't know all the ins and outs, it sounds like it's something that could be beneficial, but does it extend beyond the individual that is receiving services? Okay, well, I don't know, but I'll find out.
All right, so we do have time for one more. I'll just check in with the virtual audience if anybody has a question.
Actually, we do, Sam.
Oh, fantastic. All right, Mordecai, what is that question?
Dr. Dooney, what outreach efforts are in place to coordinate and train peers nationwide with the services of family care?
Nationwide, I think it varies by state to state. I think that, so in Washington State, there is a certification program that family members with lived experience can participate in to become family peers. And I think that varies state to state. I think in New York, there's the same process where it is a state certification process that has happened. I will say that in Washington, it's a little bit not as developed as other places. And so, but is there something that's nationally? I don't believe there is, unless anybody in here can correct me if I'm wrong. Yes. I'm going to repeat that. I don't know if somebody in the crowd said, I don't know if there's an organization per se, but there is an organization called National Peer Support. National Association of Peer Support. Gotcha. So you can become a member. You can become a member of that organization and interact with other individuals through it. I hope she was able to answer your question. I think that was a pretty good reply. Okay. Thank you so much, everyone.
Thank you for joining us for the recording of this presentation from the 2022 South-Southwest Mental Health Technology Transfer Center, MHTTC, First Episode Psychosis, FEP Conference. To learn more about this conference or the work of the South-Southwest Mental Health Technology Transfer Center, please see our website, accessible by the QR code on screen. You may also join our newsletter or follow us on Twitter or Facebook with the QR codes on screen now.